Let's talk about heart failure medication. First, you want to think about ACE inhibitors, the prils. You want to remember lisinopril. This does cause dry cough, so if this happens, we want to switch our patient to an ARB. It can also lead to hyperkalemia, so we want to pay attention for our potassium. Next, let's talk about our diuretics. So with our diuretics, you want to remember that this does cause increased urination. We want to watch out for our hypokalemia because of our increased urination with furosemide. And you also want to tell your patients, do not take a diuretic close to bedtime. Next, we have our spironolactone, which is a potassium-sparing diuretic, which means this holds on to potassium. We want to watch and monitor for hyperkalemia. Next, let's talk about digoxin. Digoxin does have a therapeutic range. You want to remember this. This is a good Nclex question to ask, 0.5 to 2.0. And for digoxin, you want to take an apical pulse, and this has to be above 60. You want to monitor for toxicity. And digifob would be used for an antidote. And we have to monitor our potassium levels. Why? Hypokalemia leads to increased toxicity in digoxin. Last but not least, we have our beta blockers. You want to remember metoprolol. And for this, you want to monitor your heart rate. And also remember with our beta blockers in our diabetic patients, this could disguise hypoglycemic events.